Welcome to ISA Telangana Webinar. This is the 19th webinar for this year. This is aimed at postgraduates as well as the practicing anesthesiologists. I welcome Dr. Ratnakar, President ISA Telangana, and Dr. Chintalakishan, Governing Council member, and today's coordinator, Dr. Srilata. She is a professor of anesthesia at Nizam's Institute of Medical Sciences. And today's speaker is Dr. Amarja Nagri. She is the consultant cardiologist at Aurangabad. So I hand over the session to Srilata.
Yeah. Hello, everyone. Very good evening. And welcome. We'll welcome the speaker, Dr. Amarja Nagri. She is a consultant cardiac anesthesiologist at Kamal Nayan Bajaj Hospital, Aurangabad. And she has, to her credit, she has got a lot of achievements. And one of them being award for education initiatives at CARC 2018 at Coimbatore. And she has got a lot of publications also, both national and international, to her credit. And also she has got an award for excellence in medical service. It is Arogya Jagruti Health Magazine. Today's topic is anesthesia of controlled hypertension. And a little brief words about uncontrolled hypertension. I think many of us, we face this problem of uncontrolled hypertension in our perioperative period. And mainly in the preoperative, obviously in the perioperative period, we face it in different scenarios, as in a pre-anesthetic assessment just before shifting the patient to the OT table, or in the intra period when there is a typical stimulation of the sympathetic fibers, or else we have again, it may be in the post-operative period due to different causes. But this, and another thing is important is hypertension as such, we all know is one of the major problems which everyone encounters during their anesthesia period per se. And as a PG student, I think they should know how to deal with this hypertension, what are the different causes of it, and what are the different steps we should need to take care of when we face such a patient with uncontrolled hypertension. So over to Dr. Amarja. Welcome to this ISA webinar of Telangana. And Madam, you can take over, please.
Thank you, Srilata Madam, for this gracious introduction of mine. And thank you, ISA Telangana. I am very much grateful to you all and the whole team of ISA Telangana for giving me this opportunity. And it is a very, very important topic. We all know anesthesia for uncontrolled hypertension. Like we as an anesthesiologist, we are always in the dilemma whenever we uncontrolled hypertension, who is having chronic illness, its main manifestation is hypertension. We are always in a dilemma whether we have to continue with the surgery or we are going to postpone this surgery. So our main aim of today's talk is what should be our correct methodology to handle such patients. Primary 10 to 25% of individuals presenting for surgery anesthesia and constitutes an important cause of cancellation of elective surgeries. Much of the fear stems from the fact that hypertension may lead to adverse perioperative outcomes. Although uncontrolled hypertension causes risk of stroke, renal dysfunction, and MACE, that is major adverse cardiac events, the same is usually not seen in the perioperative period if blood pressure is less than 180 by 110 mm of Hg. So we all are very much well acquainted with this classification of hypertension. Like there are these grades, grade 1, 2, and 3. I will not go into the normal values in detail. The grade 1 is 140 to 159 and diastolic being 90 to 99. Grade 2 is 160 to 179 and diastolic being 100 to 109. Grade 3 is more than 180 and more than 110. So we today for our discussion, we have this cutoff value of grade 3 hypertension. So what if patient is having hypertension, but it is grade 1, 2, and what if patient has grade 3 hypertension? There are mainly two concerns always. Should the detection of hypertension lead to further testing of this patient, or should we postpone this surgery? And if the surgery does proceed, what would be the expected outcome of this patient? Why are we concerned so much? What are the risk factors? What this hypertension will lead into or culminate into? It may culminate into stroke, into myocardial infarction, into congestive heart failure. It may cause acute renal shutdown, or it may later on lead to peripheral vascular diseases. It is less clear if it constitutes an increased perioperative risk, but still it is a major reason for cancellation of elective surgeries. Coming to the cardiovascular system or the cardiac system, untreated chronic hypertension may lead to myocardial ischemia and or infarction. Ultimately, both the diastolic and the systolic performances of the LV may decline over time, and this may eventually lead into congestive heart failure. Hypertension is also associated with diabetes, dyslipidemia, and obesity, which are the known risk factors for the development of coronary artery diseases. Now the CNS. CNS, we all know, is very much affected by hypertension. Uncontrolled hypertension is a risk factor for ischemic and hemorrhagic brain injury, hypertensive encephalopathy. It may lead to intracerebral bleed, subarachnoid hemorrhage, which may culminate into stroke. What happens actually? The autoregulation shifts to the right in hypertensives. Therefore, any amount of hypotension actually causes reduction in the cerebral blood flow, and this causes worsening of the cerebral ischemia. Studies have shown that the history of stroke forms a predictor for the cardiac events as well. So this cerebrovascular events may eventually lead to cardiac events also. The another system which always gets affected, any disease, there are three systems which readily get affected, are the cardiac system, the cerebral system, and the renal system. The renal system, the patient may land into acute renal failure, or even as a part of uncontrolled hypertension, chronic hypertensive patients, chronic renal insufficiency also may be present in them. Also in the RCRI score, if we all remember, preoperative serum creatinine more than 2 mg per dl is identified as an independent factor for the MACE or the major cardiac events. Does uncontrolled hypertension increase the perioperative cardiac risk? So what is your opinion? For me, yes, it increases the cardiac risk. But what do studies say? What do the articles tell us? Let us see. Or what do the guidelines say? Even I have quoted a few guidelines. Let us see what they say. There are profound hemodynamic perturbations during anesthesia and surgery. But there is no clear evidence that hypertension constitutes major risk factor for adverse perioperative cardiac events or in the patients undergoing elective non-cardiac surgery. Now, these are the few studies which I have quoted. These studies are Howell et al. Performed a meta-analysis to evaluate the effect of hypertension on 30-day perioperative MACE following surgery. The authors conclude that there is very little evidence of admission blood pressures less than 180 by 110, that is grade 1 or grade 2 hypertension if the patient has. Have very little evidence that it causes adverse perioperative complications. In other words, there is little benefit on cancelling this grade 1 and grade 2 surgeries. Got my point? But this was grade 1 and grade 2. What happens with grade 3, that is more than 180 by 110? A small increase in the incidence of this perioperative mess or major cardiac adverse events in the presence of hypertension with organ damage is possible with grade 3 hypertension. Means what? If the patient has grade 3 hypertension and has organ damage is like having kidney dysfunction associated or associated comorbidities. Then there is a small increase in the incidence that these patients may land into perioperative complications or may have major adverse cardiac events, like patient may land into heart failure, patient may land into ischemic heart changes like ST elevations may occur. So in these patients with organ damage, they say there might be incidence of this MACE can occur. But this is not clear whether postponing the surgery to reduce blood pressure reduces this study. Wexler et al. What do they say? They have studied around 1,000 patients who had uncontrolled hypertension with diastolic BP of 110 to 130 on the day of surgery, but without any evidence of target organ damage or without any gross comorbidity like previous MI or a history of revascularization, that is stenting or CABG in the previous years, or unstable angina or LVH, renal failure, aortic stenosis, and like this, or stroke. When they don't have any other organ damage and they had diastolic BP of 110 to 130, what happened to this group? What did Wexler et al. Do? They randomized them into control group and treatment group. For the control group, they postponed the surgery and the patient remained hospitalized and got optimized before surgery and then got operated. While the treatment group, they received 10 mg of intranasal nifedipine and proceeded to surgery. The frequency of perioperative hypotension, hypertension, bradycardia, or tachycardia, or any other arrhythmias was similar in both the groups, and there was no major complication in either group. It implies that patients without evidence of significant coexisting cardiac disease can be taken up for surgery even with elevated pressures on the day of surgery. So that was their conclusion. Then, what are the views of this Rice-Roberts et al.? They demonstrated increased cardiac liability and greater risk of perioperative myocardial ischemia is present in patients with poorly controlled hypertension. So they say that cardiac liability is present in them. Monk et al. Has given a very significant conclusion. This is something we have to remember, and this is something like a take-home message from today's talk. Tension less than SBP of 70, mean of less than 50 mmHg, or less pressure of less than 30 mmHg, but not hypertension per se, is associated with increased mortality, they say. So we have to just keep in mind that excessive intraoperative hypotension may be detrimental to our patient. Now, what do ACC, that is the American College of Cardiology, and the AHA guidelines say? They have termed uncontrolled systemic hypertension as a minor predictor that has not been showing any independent increase in the perioperative risk. And the British Hypertension Society, they say in the absence of organ damage, BP of less than 180 by 110 does not warrant cancellation or deferment of elective surgeries. So this is something British guidelines say, that we need not cancel surgeries in grade 2 and grade 1 and grade 2 hypertension. If BP is less than 160 by 110, with or without optimal antihypertensive treatment in the last 1 year, no further measurements are needed in PAC also. If the BP is 110 without any organ damage, then they can be cleared up for surgery. What do you mean by organ damage? Is ECG changes, history of TI or stroke, and raised serum creatinine. That is, your kidneys, heart, or brain is involved or not. That is the evidence of the organ damage. These guidelines are less clear as to what to do with patients with blood pressure more than 180 by 110 or those with having organ damage. Obviously, because there is paucity of such studies and its outcomes have not been published by anyone. The guidelines suggest that the decision to proceed with this subset of patient should be looked for other factors like associated comorbidities, functional class of the patient, and the urgency of the surgery. So the red part I have highlighted is that we have to take our decisions on the basis that it is grade 1 or grade 2 hypertension. In this, they have said that if it is grade 1 or grade 2, that is less than 160/110, you can proceed with surgery. There are very less chances that MACE will occur in them. But if they are more than 180/110 and with the evidence of organ damage, then you have to take the call by seeing the associated comorbidities, the extent of those comorbidities, functional class of the patient, and the urgency of your surgery. There is another type of hypertension, that is the anxiety-related hypertension. If significant hypertension is found in a non-treated patient, then IV sedation can help to reduce the anxiety. But if this fails to reduce the anxiety, this patient you can start treatment of hypertension in them, or you can reschedule this patient later. What is white coat hypertension? So these patients can present you as uncontrolled hypertension, but these are not actual hypertensive patients. This is something that the blood pressure rises extensively when the physician or the anesthesiologist measures the blood pressure. This may occur due to environmental stress. The important thing to note in this is that the silent myocardial infarction can be seen or is seen in them. So that is why we are worried about white coat hypertension. But they say that long-term rate of complications is similar in both. Like they are equal to normotensives only. So long-term complications, we need not worry in white coat hypertension. But even though it is due to environmental stress, we have to keep in mind that sometimes silent ischemia can occur in them as well. There is another entity, that is the elevated systolic blood pressure or the wide pulse pressure. We see blood pressure of like 180 or 200/70 or 90. This is very common. When there is such high elevated systolic blood pressure or the pulse pressure is very wide, more than 80 mmHg, this can also lead to congestive cardiac failure, coronary artery disease, or stroke and dysfunction. So this is also something like elevated systolic blood pressure is also something that can land us into problems. How do we go about these patients? Now, if we have taken these patients and we want these patients to get operated on that day itself, what are we going to do? Given the fact that hypertension may be mostly silent and may not silently, and first it is detected during the PSC only. BP of less than 180/110 without evidence of organ damage should not constitute a ground for any postponement or cancellation of surgery. I'm clear in this. Yes. Now, if you want to take this patient, what you have to do? You have to have a proper preoperative assessment and their blood urine nitrogen, serum creatinine, potassium levels, and recent ECG has to be done. If the BP is more than 140/90, you can start with antihypertensive treatment, but we don't know if this short-term treatment is going to give us any in reducing this MACE. The need for cardiac testing be asked in the presence of poor functional class, risk posed by the surgery, associated comorbidities like diabetes, renal dysfunction, or coronary artery disease. The mainstay of treatment is the antihypertensive drugs. Why should we start antihypertensive drugs as such? Because they not only reduce the BP, but they induce reverse remodeling of the LV. That is regression of LV hypertrophy. LV hypertrophy is something that culminates later on into heart failure. There's a big process. We'll not go into detail of that, but I'm just telling you what happens with this extreme LV hypertrophy is that the patients land into heart failure. That's the end point of that. So this reverse remodeling on starting of antihypertensive drugs is something we should aim for. Now, what are the drugs? The main class of drugs include the angiotensin converting enzyme, that is the ACE inhibitors, the ARBs, that is angiotensin receptor channel blockers, diuretics, and beta blockers. These are mainly the 5 divisions of drugs on whom the patient. Now, coming to the importance of which, because these drugs, they interact with themselves also, and they interact with the anesthetics also, and we have some really complications to deal with when patients are on this drugs. AC inhibitors, if the patient is less than 55 years, AC inhibitors should be started. Combination of two agents should be avoided in this because there is risk of intraoperative hypotension. And intractable hypotension is the word they use for this. Intractable hypotension can
Some discontinuation. No?
I think we just lost her. I can't see her there. So yeah.
No, that's what. I think some net problem.
Internet problem at the speaker's end, I think.
Yeah.
I am trying to call her.
Yeah, she got
okay.
logged off because yeah.
Hi, Vibha.
Hi.
So our guess is correct. So she's, yes, she entered.
Is it rectified?
Net issues. Yes. Right. Mm. Not audible.
Not audible.
Dr. Amarja, we are not able to hear. We can't hear you.
Yeah. Now
Yeah.
you can hear me?
Yes.
Yes, fine. So, sorry for that interruption. And what we were talking about is this AC inhibitors. So, although we know that it causes the risk of intraoperative hypotension, still we continue AC inhibitors perioperatively because they have immense advantages on the LV or on the heart and the whole of the vascular system also. Coming to another group of drugs which the patients are usually on is the calcium channel blockers. Patients more than 55 years, usually we offer them CCBs, and they can be continued safely on the morning of surgery, and caution should be exercised if the patient is having heart failure or is hypovolemic. They do interact with the anesthetic drugs or the inhalational drugs as such. The inhalational agents decrease the availability of intracellular calcium, which in turn enhances the negative inotropic, chronotropic, and the dromotropic effects of the calcium channel blockers. Calcium channel blockers can potentiate all neuromuscular blocking agents. They potentiate, impair the HPV, and mildly increase the intracranial pressures also. Coming to the alpha blockers, patients may be on pentolamine, prazosin, or phenoxybenzamine. They can be continued preoperatively if we need. Also, the diuretics have to be continued if the patient is diuretic dependent, that is if it is a case of heart failure. But we have to always keep in mind that they may have hypokalemia. So all the time we have to keep a watch on the serum electrolytes of these patients. Now our very favorite drug, that is the beta blockers. Mostly all the patients who have some or the other cardiac ailments are on beta blockers. Beta blockers are mainly reserved for the younger patients in whom there is intolerance or contraindication to ACE inhibitors or ARBs, in women of childbearing potential, or in those patients with evidence of increased sympathetic drive. POISE trial showed that though myocardial protection was better with beta blockers, there was great incidence of all-cause mortality and stroke if it was started acutely perioperatively. So if your patient is on beta blockers, it is very much easy to handle these patients. And if you start it abruptly or instantly you want to give beta blocker first intraoperatively, then you have to keep in mind that there might be some sort of complications that can occur, which may be due to beta blockers. And why do this occurs? Because the hypertensive effect of these doses, untitrated doses, might be worsened due to anesthesia, blood loss, or profound inflammation that occurs during surgery. We have to continue whatever the doses are there, or even the half doses are continued prior to anesthesia and surgery. Abrupt discontinuation is associated with significant rebound hypertension and tachycardia, which may lead to myocardial ischemia and infarction. This is also a very important point. If you omit beta blockers, we usually do omit for the fear of bradycardia, right? But then rebound hypertension can occur, and which becomes very much difficult to manage. So we can, if you fear about the bradycardia of beta blockers, give it in half dose, or even 1/4 dose also is okay. These withdrawal symptoms are due to the increased sympathetic activity, which is probably reflection of adrenergic receptor upregulation during the period of sympathetic blockade. Other drugs, just you have to know the IV anesthetic, IV drugs which we use are the sodium nitroprusside, but you have to just keep in mind the cyanide poisoning or the thiocyanate poisoning that can occur, especially in the patients with renal dysfunction, or NTG, wherein methemoglobinemia can occur. How do we manage this anesthetic management of these hypertensive patients? The first and foremost thing that you have to remember is the hemodynamic swings are more common and exaggerated. They are not only the fluctuations, the blood pressure fluctuations. Like one moment you may see that the blood pressure is 90 mm of Hg, and you just give little bit of fluid in them, the pressures go to 150, 160. Or if the pressures are 150 and 160 and you just increase your isoflurane a bit, and you see that the pressures have come to 100. So these hemodynamic swings which occur, they are common, not only common, they get exaggerated in these hypertensive patients. So this is one very important thing we have to always keep in mind when we are managing hypertensive patients. The rightward shift of autoregulation in hypertensive patients means that organ perfusion occurs at higher mean arterial pressures. So intraoperative hypotension is a big no-no, because it will lead to hypoperfusion and target organ damage during hypotension. So when we are dealing with these patients, we always keep a watch on mean arterial pressure, or as such the whole pressure We don't allow gross hypertension because we are always like the pressure head has to be proper. We are always keeping a watch on the kidneys, that is the urine output of the patient. And we are always talking about the pressure head, that is the blood pressure drive that has to happen for the urine to come out. So we always look at the urine bag and we say pressure head is not there, so the urine output is reduced. And so that way you have to be very much vigilant for the vital organs, that is always the heart, brain, and the kidneys. Even short periods of hypertension might be associated with myocardial and renal injury. You have seen acute kidney shutdown. Many a times you must have seen that for 1 hour or so you don't get urine output at all because the pressure head is not there. It is very important that you avoid this intraoperative hypotension. Hypertensive surgeries more than hypertensive surgeries more than 20% from baseline are also associated with adverse outcomes and should be urgently treated with the goal of blood pressure reduction. If the patient is on metoprolol, you have to continue it. Has been used in hypertension due to acute coronary syndromes. Actually, when it is related to acute coronary syndrome, patients may be on metoprolol. Nifedipine nowadays is not indicated, is not given as such. We used to use a lot of nifedipine when we started our practices. The faculty, senior faculties today who are here with me, they'll appreciate this fact that when we used to do surgeries, we used to pinch this nifedipine tablets into the nose or just beneath the tongue of the patient. Yeah. And but then the advantage used to be the uncontrolled hypotension. Nothing is in our hands. The blood pressure goes down and down and down. Yeah. So nowadays it is not recommended. We have better drugs to handle the hypertensive crisis. Anesthetic implications now. During anesthesia, the cardiac depressant effect of anesthetic medications can cause significant reduction in the SVR, especially when combined with decreased baroreceptor reflexes. This can lead to large swings of blood pressure. Hypertension is associated with large shift in the physiological autoregulation curve, particularly the cerebral blood flow. Caution is warranted as the risk of cerebral hypoperfusion during anesthesia is always there. So again and again, I'm saying avoid hypotension in these patients. Now, why do hypotension will occur? Hypotension will occur mainly because of systemic vasodilatation, because of sympathetic blockade, hypovolemia, blood loss, mechanical ventilation, drugs, arrhythmias, or any acute coronary events. Per se, hypertension can also occur during anesthesia and surgery due to surgical stimulation, laryngoscopy intubation, inadequate plane of anesthesia. This is very, very important. Hypothermia, hypervolemia, extubation, and inadequate analgesia. Why I have quoted all these points is because we have to correct all these points before we go on to giving cardiac drugs. Everything has to be sorted before we use the IV cardiac drugs to monitor the hypertension or to manage the hypertension. What are these drugs? These drugs are mainly the IV nitroglycerin, that is NTG, sodium nitroprusside, the beta blockers like labetalol, esmolol, hydralazine or clevidepine, which we usually don't use, but the first 3-4 which I have quoted like the NTG and the beta blockers we do use a lot. Monitoring as such, invasive arterial blood pressure monitoring is not required unless the surgery is very high risk or if the patients are on vasoactive drugs. Central venous monitoring is needed as per the cases. Pulse contour cardiac output monitoring may not be effective in this patient as they are based on the normal arterial compliance, which is lost in this patient. Now, coming to the induction of anesthesia, we all are very much vigilant and we know about how to induce this anesthesia in these patients. But let me just brush up saying that induction agents like propofol, fentanyl are acceptable only and only when they are titrated slowly. Hemodynamic changes with induction may reflect the decreased intravascular fluid volume. Patients are NBM, patients are hypovolemic, and that is why the hemodynamic changes may get exaggerated. That always we have to keep in mind. During direct laryngoscopy, there may be strong sympathetic response, which has to be avoided with proper analgesics, beta blockers, IV lubricant, and all the other strategies that we know. Intraoperatively, maintaining the blood pressure within physiologic parameters for a given patient based or preoperative levels has been the mainstay on anesthetic management. Avoiding significant hypotension is particularly important in preventing anesthetic complications. For the postgraduates present here, I want you to tell me, I have written here the different strategies. I want to know what all different strategies do you use in managing the blood pressures before going to giving NTG or labetalol or esmolol or metoprolol. Yes, what all do we do effectively and what is the sequence of that? So the postgraduate students who are available here today, who are present here, have to tell me all the other strategies. Few I have already quoted here. What more do we give during induction of anesthesia? That you have to tell.
You can either switch on the microphone and tell, or you can type in the chat box.
Yes, sir.
No, I am asking the PGs.
Excuse me. You can hear me?
Yes, we can.
You know. We can discuss it at the end also. Only few slides are remaining. We will discuss again at the end. Yeah.
Sure.
I have few more questions for them, so we can have a good 10-minute discussion on that. Now, post-operatively, you also, if the patient you have shifted to the recovery room, then you have to bridge these patients with appropriate medications that they do not go into hypertensive crisis. Now coming to the conclusion. So the main thing what I want to stress is that it is not merely the elevated blood pressure values, but what these values do to the organs is what constitutes risk. A diabetic patient may be of greater risk of myocardial dysfunction with intraoperative blood pressures of 150/90 than an individual without any risk factors. Therefore, it is important to be careful, not necessarily fearful, as care improves patient outcomes, whereas fear results in unnecessary delays and case cancellations. So these are my references, and that was all from my side today. It's a very vast topic, and there are so many points yet to be discussed, but I have just taken important points, and the common points I have just kept for discussion, and that should be told to us by our dear postgraduates. Let's see. And this is my book. This is a very motivating and inspirational book. It is You Are a Star. It is readily available on Amazon, and you should read it, and you should know how to pave your way to success. So this is something that will help you to become super achiever. So that was all from my side for today, and let us start the discussion part. Sir.
Yes, thank you, Amarja. It was a nice presentation and wonderful conclusion also. So, and you have initiated the discussion as well, and let us see our postgraduates how they respond. Any postgraduates?
Dr. Amarja, please play the show the slide which you were asking the question.
Yes.
I think a lot of postgraduate students should come forward and ask.
Yes.
There is.
Because this is not basically for the faculties, right? Because faculties are managing it well. Yeah, so, and we need not even answer in exams all these things. So it is the postgraduates. What I want is that, what is the sequence? Now, I'll give you an example. Like if your patient has a blood pressure of 180/110 and is coming for laparotomy, laparotomy can be postponed only 1 or 2 days if at all you want. Yes, but sometimes it is not possible to postpone also. You have to do it on the very same day. Now your patient is having diabetes and patient is posted for laparotomy, 180 by 110. What all investigations are you going to look for? Any postgraduates, please come forward. I had seen 2-3 students on camera before some time.
Srija? Srija, Suryakant, Sanskriti, Deepika, anybody?
These are very basic questions, very, very basic questions for MD students, for diploma students. Yeah.
2 answers we got, I think, in the chat box.
Okay. Yeah, chat. Okay, fine.
Routine surgical profile, ECG, serum electrolytes.
See, Suryakant is asking significance of diastolic dysfunction in anesthesia implication. Suryakant, this is the very basic questions you need to understand, and you have to answer first. Echo findings of diastolic dysfunction is itself a very huge topic. And Suryakant, I have a very beautiful lecture on YouTube for this. So you just type my name on YouTube and you type this diastolic dysfunction echocardiography for diastolic dysfunction. It is 1 hour lecture you will get. So go through it. Otherwise, you can just contact me. We will discuss that. But that is very high five. Your Viva will not go to that level if you don't answer my 3-4 questions here as of now. So these are the basic questions. This is the ladder. No, you have to go through that ladder first, right? So we have to be perfect at every step. So just answer these questions. Routine surgical profile, ECG. Okay, ECG is one. Okay, fine. What is routine surgical profile? Serum electrolytes also he has written. Okay. And what else do you want? Okay. Because of paucity of time, I will tell you how do we deal with such questions in exam. First, what you have to say is, if the patient, I get such patient, this patient has uncontrolled hypertension, that is need of renal Doppler in evaluation. Okay. Yes, renal Doppler can be done, but the basic evaluation has to be done first. So when you have such patient, you have to first see that the blood pressure is uncontrolled. You have to see for the history. What all history you will ask? You have to ask for the history of stroke or TIA, renal shutdown, history. If the patient has any problems for urination, has he visited the urologist earlier? Has he visited cardiologist earlier? Does he, or physician earlier? Has he taken ECG anytime? Did he have any eyesight problem due to hypertension and diabetes? Does he have diabetes? Okay, then see all the systems you have to see. Like you start from brain, you have TIA or stroke, history of TIA or stroke, or just ask for the syncopal attacks. Some people may have that, or they just get blackouts, something like that history. Yes, or you can ask for the tingling and numbness history. There are so many things you have to ask for that. So you have to go, and kidney and the heart you have to rule out. Okay, you have to see if previously any time ECG was done. Is the patient on any tablets? Mostly these patients are on ecosprin. They won't tell you. Ask them about ecosprin tablet. Ask them about any other tablet do they take. Fine. And after that, you go for the routine investigations like ECG, echo. He's 65 years old, I said. So is echo done? What does echo say? Then see for the serum urea creatinine electrolytes. Electrolytes also I said, but no one has written that in comments. So electrolytes also are very, very important, because the patients will be on diuretics or any other drugs, or we have to give them diuretics. Eventually you are going to give him hypokalemia along with diuretics. So there are so many things. Okay. And after all these things, when you are giving laparotomy, Now going for laparotomy. Now during induction, my basic question is, what are the other strategies that you are going to use? Yes, one or two I have already written. There are the beta blockers or IV lignocaine, which we give. Some people even give magnesium. Do you know that there's a role of magnesium also in hypertension management? So this beautiful this what does magnesium, like from my side, this is some bonus points for you all PGs. Like magnesium, what it does basically is, it is a calcium channel antagonist. So it stimulates the production of this vasodilator prostaglandins and nitric oxide. And therefore it is very, very important that you give at least like 1 gram, even 500 milligrams is also okay, but 1 gram, maximum 2 grams, even up to maximum 4 grams they have given magnesium, and that they have found it is very important. Also, another point about magnesium is that it increases the efficacy of other antihypertensive drugs. And also third point is, mostly these patients are magnesium deficient most of the times. So that also helps. This takes care of the arrhythmias also. If they are going to throw arrhythmias due to any reason, that is also taken care of. Okay. Another drug which is very, very important in case of these patients is dexmedetomidine. Many people like dexmedetomidine. Yes. So you can give it bolus, or you can use it in infusion method for your sedation. That is also very, very important. Now, coming to this, firstly, what you have to do is, you have to deepen your plane of anesthesia. You have to increase the isoflurane. You can use your drugs like dexmedetomidine. Even the hypotensive effect of propofol can be used here. If there is a sudden surge of blood pressure intraoperatively, you can make use of propofol, which we all do. Yeah. And then after using all these drugs, if you want, still there are surges of blood pressure, then you go for nitroglycerin, that is NTG. Fine. There is one more advantage of using NTG. What is that? Can anyone come up with that? Because I will tell you that NTG, what it will do, it will make your LV supple. The contractility of LV will increase. The strain on the LV will be decreased due to NTG. So never fear to use NTG. NTG is a wonderful drug. Only the hypotension you have to manage. But once you get the idea of how to use NTG, nothing like it. Also, you can use metoprolol, that is beta-lock, labetalol, and esmolol. These are the usual drugs which we use. And this is something I wanted to emphasize in the drug or the management part. So over to you, sir.
Thank you. Dr. Srilata is there?
Yeah.
We have senior faculty with us today, Dr. Deepra Singh sir, Dr. Sherry Matthews sir, and Dr. Vibha is also there. Any input, sir? Deepra sir?
Yeah, am I audible?
Yes, sir. Yes.
Yes, sir.
Yeah. In today's era, you need not worry about the hypertension so much. Only thing is, I have seen the people who have been postponing the cases because of the little hypertension. Even with 150/90, they are afraid of taking the case for surgery. They unnecessarily, this postponement or this unnecessarily delay in the surgery should be avoided, because we have so many nice drugs nowadays. So there is no reason why you should, unless it's a very high blood pressure and case is very elective, unless that is done. For small reasons, I have seen the trend is that they first come out with the postponement of the case. That should not be done. You think why it is, and you have so many drugs at your disposal that you can maintain these things. For small cases, instances, you need not postpone the case. This I wanted to stress.
Thank you, sir. Dr. Vijay Mohan, sir. He is a cardiac anesthesiologist as well. Dr. Vijay Mohan garu.
Dr. Ramakrishna, can I talk?
Yes, sir. Yes, please.
Yeah, Matthews.
No, no.
Yeah, Matthews.
Just to get around Dr. Deepraj's this thing. See, the main problem is we don't keep ourselves up to date of what is happening.
Yeah, that's
So
what.
there is absolutely no evidence based for postponing a case.
Yeah,
So I think as teachers,
Yeah.
it's very important that we keep ourselves up to date of what is happening in our
What
specialty.
is happening?
We
Yeah,
talked about 20 years back and keep postponing cases.
yeah.
So this is what is happening in our department, and that we are not able to imbibe in our PGs also,
Yeah, just
to get into the habit of reading the latest evidence and presenting it. So I think if we as teachers could imbibe that, probably the PGs will have all the latest evidence-based medicine with them. So Madam has given a very good lecture, and I've been continuously in contact with my PGs to just listen to it and see that cases are not postponed unless there are reasons which Madam has very clearly mentioned.
clearly mentioned. Yes.
Thank you, Dr. Amraja, for that
Thank you, sir.
very
Thank
good
you.
lecture which you have given.
Nice presentation, Amraja.
Yeah.
Thank you, sir. Thank you.
Dr. Amraja, I've got one simple question.
Okay.
Say, AC inhibitors are now frequently used drugs for regular as antihypertensives, and the effect of AC inhibitors under general anesthesia, do they prolong the effect of the, or else reverse, prolong the what is it, rocuronium or vecuronium, whatever the relaxant to use, or else any contraindication with the AC inhibitors under general anesthesia? Shall we postpone it for 1 or 2 days, 3 days? Is it required?
When the patient is on AC inhibitors?
Yeah.
No, sir. There is no need. Actually, in cardiac surgery, we find it very useful, AC inhibitors.
At
And
least the day before the surgery or 1 day before?
we continue it on the day of surgery also, AC inhibitors. Only thing is that you have to manage the intraoperative hypotension. That can be like intractable or exaggerated hypotension can occur in them. So we have to always keep in mind, because the advantages that AC inhibitors offer are good or are more. So they say either you stop it, but then rebound hypertension can be present. But if you want to continue it, you have to take care of the hypotension, intraoperative hypotension that can occur. And that usually occurs if you combine 2 to 3 drugs. So we can continue it.
The hypertension is more at induction when the patient is on AC inhibitors or ARBs. Yeah.
Yes, induction. And sir, after the induction, hypotension is more, because then the combination of all these drugs happen, we give so many drugs at that time. We give propofol, we might give sedatives earlier, midazolam. So we see hypertension surge during induction, and just after induction, we are bound to get pressures which are like 90 mm of Hg or something like that. Yes.
Okay.
Dr. Srilata?
Conclude.
Good evening, sir.
Okay. Shravan, yeah, welcome.
Good evening, sir.
Good evening.
Ma'am, one small question. I'm right now a little bit away from evidence. What is the present evidence as far as the continuation of AC inhibitors for non-cardiac surgeries in perioperative period? Traditionally, they say they have to be stopped 24 hours earlier and try to optimize the hypertension on other class of antihypertensives. What stands hold good today, madam?
So today, the guidelines say that you can continue the AC inhibitors, provided you have to keep a watch on the intraoperative hypertension. So they warn us about the intraoperative hypertension that can be caused, but they tell us that there are enormous advantages of having AC inhibitors ongoing. So they say you can take the patients, you need not stop AC inhibitors, but you have to take care that they do not cause deep in the blood pressures. That is the intractable hypertension doesn't occur. So you have to take care of all these things.
One more small question, ma'am.
Yes, sir.
traditionally, we induce the patients with a co-induction technique for cardiac surgeries with a combination of presently available fentanyl, midazolam, and either a thio or propofol, along with the combination of inhalational agents depending on availability, either a CO or a isoflurane. What is your experience as far as the etomidate is concerned as a part of co-induction technique? They say that it's a very cardiostable drug. What is your experience, madam?
Sir, daily I do 2 cases of cardiac. Yes. So daily I use etomidate. For every case, my strategy is using fentanyl and etomidate combination. I like that combination, fentanyl and etomidate. So it is opioid plus etomidate I use widely. And if there is a surge, I use a little bit of propofol for that. And for sedation, I usually don't use midazolam. But if people are fond of midazolam, they can use it. But for me, midazolam causes hypotension. So I don't use midazolam as such. And I use isoflurane along with this. So my every patient I induce with etomidate. They say that etomidate is very cardiostable. I find etomidate cardiostable too. But then I have never given 10 ml of etomidate also. I use half dose of etomidate. So what my strategy is usually is that give the drugs to get their advantages and avoid their disadvantages. You got my point. Like I don't use etomidate because lot of etomidate, 10 ml of etomidate can also cause hypotension. It is
what dosages you usually use, ma'am?
I use 50 mg. That is, I use 5 ml maximum in an adult patient of 60 kgs, plus 200 to 250 mics of fentanyl plus isoflurane.
Okay.
That is my induction strategy, along with vecuronium. So what is your strategy, sir?
In OPCAP cases, madam, what?
In
OPCAP cases, what strategies you follow for maintaining the heart rate, madam?
Sir, basically what we do is, if your surgeon or if you prefer a heart rate of about really in between 50 to 60 per minute, previous day metoprolol you have to give. Also we give Nicoran tablets on the previous day and in the morning of 2 hours before surgery. So you can follow that if your surgeon prefers, or you prefer 50 to 60. But I myself don't prefer 50 to 60 heart rate. I prefer 70 to 80 heart rate. So what I do is I don't give Nicoran tablet, and I even don't give full dose of metoprolol tablet, that is Bitoloc. I do give 12.5 mg of Bitoloc tablet in the morning, 2 hours before surgery. That is, I ask them to take at 6 a.m. when the patients are posted at 8:30. 6 a.m. 12.5 mg of tablet Bitoloc. That's it from my side. I even don't use in an anxiolytic as such, because we give it later on a lot of the sedatives. So I don't prefer that. I don't prefer patient very sedated and all coming in OT. So that is my strategy.
Intraoperatively, if there is any increase in the heart rate, how do you manage, ma'am? Like either with metoprolol or esmolol?
No, previously I used to use a lot of esmolol, but esmolol action is very, very short-lived. Okay. So you have to keep on giving 2, 3, 5 ml. There is no end to it. Sometimes if you are apprehensive along with that surgeon, you give that full vial. Means I have not given, but I have seen people doing that thing. So better use Bitoloc along with all the other strategies like isoflurane and your NTG. You always have NTG infusion going on, right? So I am so much friends with NTG. Basically, I purge NTG. I give NTG slowly. I give propofol 2-3 ml from here. Then isoflurane is there. Yes. So at all my hands, I have few drugs, and then fentanyl is also the best thing. If still you want, midazolam works wonders, but I fear midazolam because it causes too much hypotension for me. People use it like 2 ml, 2 mg, up to even 5 ml. People use midazolam, but I'm scared of using midazolam that much because it causes fast hypotension. If you have observed in your practice. So for me, it is always the isoflurane. One more trick, what I do is I'll tell you today. When you want like that hypotension and the patient surgeon is waiting for that blood pressure to come down, what you have to do is now you have to increase your isoflurane and you have to increase the respiratory rate of the patient. Decrease the tidal volume so that your minute ventilation is maintained and increase the respiratory rate. That means you are just giving more of isoflurane fast. Got my point? And you do this and your blood pressure will come down fast so that your surgeon is not waiting for you. Like he wants to do top end and then 130, 140 and you're waiting for 80. So you have to just increase your heart rate, little isoflurane from this side. And that works a lot, works basically very nicely.
Last question, madam. How much heparin do you use and protamine for off-cap surgeries?
Okay, now this is a very good question, sir. See, 2 mg per kg is what I like, I prefer. And most of the times, 99% I give 2 mg per kg. Okay, that is 200 units per kg. So I give 2 mg per kg. My one surgeon likes 1.5 mg per kg. So for him, I give 1.5 mg per kg. Okay, and then whatever I give, so if I give 2 mg per kg, like you say 50 kg patient is there, I give 10,000 units. Okay, and then what I do is, after 1 hour, I repeat 2 mg or 2,000 units after every 1 hour. And then at the end of the, when I have to give protamine, what I do is, what was the initial dose I had given, half of that protamine I give. You got my point?
Yeah. 1 mg per
So I
kg
think
protamine.
usually that is the way. Usually that is the way it is done, right?
Thank you, madam.
No, I have
you.
seen some people doing, they calculate the total amount of heparin that is given and then they give half of that.
Yeah.
But I don't follow this.
Okay. Thank you, madam. So nice of you.
Thank you, sir. Thank you.
Yeah, another tricky situations everyone faces is usually the case gets cancelled and then the patient on ARB or AC inhibitors, like the next day again, as per the guidelines, the PG student
yes.
has a query
Yes.
whether to continue or to give the next dose for the other
Madam,
day.
I want to emphasize what I said, no, like why I don't give sedatives and metoprolol also. Preoperatively, I told I don't like to give more of beta lock or anything, because if the surgery gets cancelled, in your ward, the patient is with the heart rate of 47 and 48 and fully sedated. So the apprehension of relatives is so much. And even if when you go and visit, you go for some other work, and if you see the patient is with 47, 48, you are only worried. So that is also one reason. Previously in my practice, I have done all these things. And later on, I just thought if the patients get cancelled, then they and their relatives have this apprehension.
Yeah, my query is like, it is not related to hypertension. The cancellation is not due to hypertension, rather due to other causes, and the patient is on ARB or AC inhibitors rather. Like beta blockers, mostly as per the guidelines, everyone continues the doses. But ARBs or AC inhibitors, usually if they are not taking the drug, the next day usually the patients, some of the patients we see, they come up with very high pressures. And then the next day again, they won't be taking the drug. So it's like very high pressures. And the PG students, as per the guidelines, like they won't again advise to go for ARBs again.
Yes. But,
that's where the problem comes.
Now what happens if the patient is postponed on Monday and if taken on Tuesday, you can't do anything. There's no time to start, or one day you stop, one day you start. Yeah. So for 2 days, it's okay. It is stopped. You just take it and you bear the consequences, whatever it is. Like that it is. Yeah. There are no any guidelines as such for these scenarios which we practically face. Yes. If the patient is like handed over to cardiologist, and if or some other problem is there and the patient is postponed for 3-4 days as such, yes, then you can restart them and then again stop them and something like that. But if this 1 day delay is there, then we have to manage it on table, just like that.
Yeah.
Ma'am,
You know,
how about-
I don't
how
worry.
about-
One more very important thing, practically, I'll tell you. I don't actually worry about all these things as such. Maybe I'm cardiac anesthesiologist, that is why, but still I will tell you, for everybody, you know, these patients are very much defaulters. They have so many reasons with them for not taking medicines at their home. You're getting my point?
Yeah,
Like
we
many
also
a times
face
they
this,
don't
yeah.
have medicine. Yes, because they don't have money to buy medicine. They have nobody to buy medicines. Their shops are very far away from their villages and so many things. So they're used to all these things, you know. So you need not worry so much that one day they have taken, one day they have not taken. They are defaulters. So it is your efficiency in drop only, and we have armamentarium of drugs and everything with us. So we have to be just confident that I will do this patient in the best possible way, and I will apply all my knowledge, and just keep updated, and you have to have good knowledge about the drugs basically, and that is how we have to manage.
Thank you. Thank you very much.
Thank you, ma'am. Thank you.
Dr. Ramakrishna, I think maybe we can wind up.
Madam, you can conclude.
Yeah.
Shweta, madam,
Yeah, that's what.
you can.
Dr. Amaja, it's a very nice presentation, very clear, with a lot of clarity. And I think the postgraduates must have benefited a lot from this, though they're not speaking up, but I think they must be benefited a lot. And thank you very much. And that's all. That's all for the.
Thank you,
That's
ma'am.
all for-
Thank
See
you.
again, Amarya, some other time. Right. Thank you. Bye.
Thank you, sir. Thank you. Thank you.
Thank you. So have a good night. Have a good day. Have a good night. Hi, Shravan.
Shravan,
Shravan.
not responding. Must be busy in a case. Scrubs లోనే ఉన్నాడు కదా.
Chalo, okay.
Okay,
fine, that's
because
fine.
I have to stay until end. I have to end the meeting. That's why I'm staying.
Yeah, I can understand.
Host.
Chalo.